At this point, I would like to introduce our speaker today, Dr. Dan Burkhoff. I've had the pleasure of working with Dr. Burkhoff multiple times in the past, and I can confidently say that we couldn't have asked for a better key opinion leader in the area of PV loops to kick off this web series. Dr. Burkhoff is an adjunct associate professor at Columbia University who engages in various research endeavors relating to cardiac dysfunction and advanced heart failure therapies. In addition, he is involved with various medical device companies who focus on developing clinical products for improving treatment and care of heart failure patients. So without further ado, I'd like to have Dan join us.
Thanks very much, Andy. Yes, I'm here. Thanks very much for the introduction.
You're very welcome.
And I'm also very pleased to be able to give this lead-off lecture on this series of pressure volume analysis. So that's the main topic of what I'm going to be discussing today is cardiovascular physiology and hemodynamics, mainly as viewed through the window of the pressure volume diagram. Now, who is this relevant for? If your research involves studying the effects of genes, of cells, of matrix, of drugs, of a device on cardiovascular properties, there are several key concepts and indexes and measurement techniques that you should be aware of that will help you in properly interpreting the effects of your intervention, or even if you are studying basic aspects of physiology of principles of disease. These common characteristics that need to be understood include the following four fundamental aspects of cardiovascular physiology. They include the concepts of preload, afterload, contractility, and lusitropy, the last one being the study of diastolic properties of the heart. So these four concepts are frequently, people get a little bit mixed up about them, but when you develop a system for understanding what these are and use the pressure volume approach, everything becomes relatively simple and very clear. Some people seem to be intimidated by pressure volume analysis, but it really could not be simpler if you just understand a few basic principles and take a little bit of time to go through what you're looking at. There are a couple of resources I want to mention. We had written a review article a couple of years ago with some of the world leaders in developing both the use of pressure volume relations for systolic and diastolic assessments, and this publication is readily available. And the other more recently available resource that I'm going to talk about and I'll show later is an application for the iPad, which is an interactive simulation textbook that allows the user to actually learn about the concepts I'm going to talk about, and also provides an environment for interacting with the computer simulation to explore the concepts in detail. And if I can just give you a very quick overview, and I will go into further detail on this later. This is the opening screen of the app, and the app will be presented in four parts that go from basic concepts all the way through advanced therapies for patients with different kinds of cardiovascular diseases and drug therapies. And part one reviews the basic concepts. There is a textbook that goes through many of the topics in much more detail than I will talk about today. Again, book one really deals with the fundamental aspects that you need to learn. And when you turn the iPad to its side, you enter a cardiovascular simulation that you can then interact with and change many variables, preload, afterload, etc., and contractility. So I will show some features of this app later on in a little bit greater detail. But these are the two resources that would be readily available if one were interested in getting further information. Now, everything that I'm going to talk about is going to be based on ventricular and circulatory hemodynamics at a macroscopic level. But of course, it's very important to appreciate that everything that I'm going to talk about really goes back to the fundamentals of muscle physiology, and specifically to the sarcomere, and to a certain extent to calcium cycling on a beat-by-beat basis. So everything that we study at the whole heart level really goes back to understanding what's going on at the at the myocyte and the sarcomere level. So, of course, one of the fundamental relationships that exists in the sarcomere is its ability to change force as the length of the sarcomere is increased or decreased. So there's a passive force-length relationship that's shown here in blue, and there's a active or peak activation relationship between force and sarcomere length that's shown by purple, and the developed pressure, the developed force, sorry, is the difference between these two. This is the amount of force over the passive force that the muscle is generating. So whenever we do talk about things at the heart level, whole body level, we have things in mind at the cellular and molecular level. So the analogs of, if you will, of force and length are pressure, volume in the intact heart. And of course, there are very complex transformation going from pressure and volume back all the way down to force and length. But almost every phenomenon that's been studied at the muscle length, muscle level, has been confirmed to be present, at least qualitatively, at the whole heart level. So in a way, doing studies in the whole heart allows you to have a window back what's going on at the sarcomere level. And of course, at the end of the day, what many of us are interested in is what determines the cardiac output, the blood pressure in the arteries, and what determines the pressures in the veins. And that really depends on the complex interaction of the hearts and the vasculatures, and also its regulation by the autonomic nervous system. And I'm not going to have time to go into it today, but there are now very relatively simple but thorough ways of dealing with ventricular vascular interactions that allow one to get extremely detailed understanding of the determinants of these important parameters if you understand the basic concepts of preload, afterload, contractility, and lusitropy. So that is really the carrot at the end, is to be able to understand what determines these factors and how they how the characteristics of each component of the system interact to determine these parameters. So with that as kind of the background, we can now launch into the physiology of the intact heart. And the foundation for understanding the cardiac, what happens, the events that occur during the cardiac cycle have been known for over a century, and they've come to be readily and commonly illustrated by what's called the Wiggers diagram. This was presented by Carl Wiggers in the 1920s, and what he did was just make a time plot of the various parameters that one could measure that characterize heart and vascular properties. So here you see on the pressure domain, you've got left ventricular pressure, you've got aortic pressure, you've got left atrial pressure, and in the middle panel here you've got the ventricular volume, and at the bottom you've got the electrical events, the electrocardiogram. And this just lays out kind of the events that occur during a typical cardiac cycle in the time domain. And this was very important to start understanding the different parts of the cardiac cycle, and provided a lot, the launch of understanding, of giving a system for understanding hemodynamics. But it turns out that it's much more informative, actually, if instead of looking at things in the time domain, we look at things where we plot pressure and volume versus each other in the pressure-volume domain. And such a construct exists for each of the four chambers: left ventricle, left atrium, right ventricle. And there are, interestingly, there are differences in the configuration and the characteristics of the loops for each of the chambers. The atria have a very different pressure-volume characteristic than the ventricles, and the right and left ventricles have different characteristics. But in principle, all of the main concepts I'm going to talk about apply to each chamber. So I'm going to only deal with what's going on at the left ventricular level, and the other resources that I've mentioned already go into further detail on the atria and the right ventricles. So what's shown on this slide is a pressure volume loop in red, and this is called a loop because with each cardiac contraction, It starts in the bottom right here at end diastole and sweeps around with each contraction through a predefined a sequence of events that describe the cardiac cycle. The cardiac cycle begins at end diastole. With the onset of contraction, you enter the first phase of the cardiac cycle, which is isovolumic contraction. When the pressure rises above the aortic pressure, the aortic valve opens, and you've got the ejection phase. Then when the aortic valve closes at the end of systole, you've got the isovolumic relaxation phase, and then the mitral valve opens when the pressure in the ventricle falls below the atrial pressure, and then you have the filling phase. The filling phase is further divided into two phases, the rapid filling phase, which is passive, and the atrial kick, which occurs towards the end of filling, which is induced by the contraction of the atrium. So you've got here a relatively rectangular shaped loop. The sides are the four phases of the cardiac cycle: isovolumic contraction, ejection, isovolumic relaxation, and filling. And the valves open and close at the corner of this rectangle: mitral valve closing, aortic valve opening, aortic valve closing, and mitral valve opening. There are important pressures and volumes that are retrievable from the loop. The width of the loop is the stroke volume, because the largest volume is the end diastolic volume and the lowest volume is the end systolic volume. So the width is the amount of volume that's ejected. That's called the stroke volume. There's also another index which is important to understand, which is the ejection fraction. Ejection fraction is defined as the ratio between the stroke volume and the end diastolic volume, and is the fraction of blood that exists in the ventricle that is ejected during the beat. And that index has been linked is commonly used as an index of ventricular contractility. There are several limitations of the use of that as an index of contractility that occur especially in certain disease states where the loading conditions on the heart are abnormal, because this parameter, ejection fraction, is not fully independent of preload and afterload. So therefore, does not truly provide an index that is independent of preload, afterload, and uniquely describes what's going on in the heart. Another important parameter is the cardiac output, abbreviated CO, and the cardiac output, of course, is the stroke volume times the heart rate. So by looking at the loop, you get important information from these volumes and also from cardiac output once you have knowledge of the heart rate. In terms of pressures, there are at least these 5 pressures that you can pick off of the loop. The starting pressure is called the end diastolic pressure. That's the pressure that exists in the ventricle at the start of ejection. And the right upper corner of the loop is where the aortic valve opens. The peak pressure of the loop is also the same as the peak pressure in the aorta. That's because during this ejection phase, the aortic valve is open, and the pressure in the ventricle and the proximal aorta are basically equal. So the pressure that is at the peak of the ventricle is also the same as the systolic blood pressure in the arterial system. At the end of ejection, we've got the end systolic pressure, PES. And note, as shown in this loop, the peak pressure is not always the same as the end systolic pressure. So you should not mistake peak pressure that the ventricle is generating or the peak pressure in the aorta as being equivalent to the end systolic pressure. Finally, we've got the left bottom corner of the loop, which is basically the pressure at which the mitral valve opens, and that is equivalent to the mean pressure in the left atrium, roughly. So those are important pressures retrievable from the loops. So we've reviewed the volumes and pressures of that you can get from looking at the loop. Now, the loop that I showed was just drawn on the pressure volume plane, but it turns out that this loop falls within important boundaries that define the systolic and the diastolic properties of the ventricle. On the upper left corner, the loop will hit what's called the end systolic pressure volume relationship, shown here in green, and at the bottom right, the loop will hit the end diastolic pressure volume relationship. The end systolic pressure volume relationship is roughly linear and describes the end systolic properties of the chamber. whereas the end diastolic pressure is pressure-volume relationship is nonlinear, and this describes the properties, mechanical properties of the heart when it's in its most relaxed diastolic state. What determines where inside of these boundaries the loop exists, and also the shape, the width, and the height are determined by the preload and the afterload. And we'll see a little bit of that in just a minute. So again, the end diastolic pressure-volume relationship is nonlinear. There's usually a V0 value. That means the highest volume that you can put in there without raising the pressure significantly. And it's usually described by some form of a nonlinear equation. There are different forms. This is a commonly used one, which shows an exponential rise with a stiffness constant of alpha above the V0 value, which is that volume above which the pressure starts to rise. So this is a typical equation that you would use to describe the end diastolic pressure-volume relationship. On the other hand, as I mentioned, the end systolic pressure-volume relationship is linear and can therefore be characterized by two parameters, the volume axis intercept and the slope, which is called end systolic elastance, abbreviated EES. With this construct, it's very simple to interrelate end systolic volume and end systolic pressure with this simple linear equation. End systolic volume equals the end systolic elastance times the difference between the end systolic volume and the V0. This equation comes in very handy, especially when we're starting to deal with quantifying contractility and also understanding aspects of ventricular vascular interactions. So again, the end systolic and end diastolic pressure-volume relations provide the boundaries within which the loop exists, and where it exists and the shape that it takes on is determined by the preload and the afterload, as shown in these two slides. This one on the left showing changes in preload, and this one on the right showing changes in afterload. Let's just go a little bit deeper into the concepts preload and afterload. And again, just to remind you that the basis for these relationships, both in systole and diastole, are found in the sarcomere. Then we know that as we change sarcomere length, we change the passive properties, the passive force that is generated by the sarcomere, but also the active force that the sarcomere can generate at end of systole, at peak systole. This is called the so-called ascending limb of the force-length relationship, because in cardiac muscle, as you stretch the sarcomere, the force increases. And in cardiac muscle, there's a restraint of how far you can stretch the muscle that's imposed by the extracellular matrix and the cell membrane itself. So we never reach, in cardiac muscle, we really don't reach the descending limb of the sarcomere length, force-length relationship unless you destroy the sarcolemma. So we're always working really on the ascending limb of the force-length relationship. So preload is defined really as the load imposed on the ventricle at the end of diastole. The most common measures of preload are end diastolic volume and end diastolic pressure. So in the sarcomere, the preload really is clearly and easily defined as the sarcomere length. In the heart, it's a little bit more difficult. End diastolic volume is one of the potential candidates for defining preload, and that works very well if you are working in an individual heart and you want to describe changes in situations that are occurring over short periods of time. However, if you are in a situation where you're comparing, say, the physiology of multiple different hearts that have different sizes due to biological variation or disease states, a volume will not necessarily mean the same thing in a small heart as it does in a large heart. For example, a mouse heart and a dog heart have the same basic sarcomere function, but their volumes are vastly different, and therefore volume becomes more difficult to use as an index. However, on the other hand, end diastolic pressure is a parameter that is relatively, would be size independent and can be used in a sense to compare situations in different sized hearts under health, disease, or growth, or in different species. So these two parameters are used depending on what the application is. And in fact, both the terms preload and afterload I prefer to use as an adjective as opposed to a noun. So for example, I would always say the preload volume is such and such, or the preload pressure is such and such, rather than assuming that when I use the word preload that someone knows exactly what I'm talking about. So here's a pressure volume loop that exists with a fixed, a given baseline preload. Now, if I do something to the body that increases the preload, this is what would happen. An example of how to increase preload is by just simply giving a bolus of fluid into the venous system, and you will have an increase in the volume in circulation, and that will wind up increasing the pressure and therefore increasing the volume from which the heart ejects and the pressure from which the heart ejects. When you do this, the pressure, the height, and the flow, the width, generating capacity of the heart increases. And this is a manifestation at the whole organ level of what we saw at the sarcomere level, where when you increase the sarcomere length, the force generating capacity increases. So this is what you see with an increase in preload, and this is what you see with a decrease in preload. For example, if you have a hemorrhage situation where you lose fluid, your starting volume is decreased, and your force generation, your pressure generation, and your stroke volume, your cardiac output, are decreased due to a decrease in the preload. Note that, again, the loops exist within the boundaries defined by the diastolic and the systolic pressure-volume relationships. Also note that as I change preload, there are significant changes in the pressure generation that the heart is able to achieve. And this is despite the fact that in this construct here, we've not changed anything about the vascular system. So when we think about these different terms, afterload, preload, contractility, we want their definition of each of these terms to be independent of what's happening in the other components. So in other words, when we define preload, we want it to be independent of afterload. So, and vice versa, when we define afterload, we want it to be independent of preload. So here you see that as I change preload, the pressure in the aorta is changing. So that gives us a hint that we don't want to use aortic pressure as an index of afterload when it relates to the ventricle, because the pressure is changing even though I'm not doing anything to the vascular system. So this shows the situation with preload, but then what about how do we talk about afterload? So again, there are many possible definitions that one could use to define afterload, and these all depend on what your purpose is. These range from looking at myocardial wall stress. I just mentioned about arterial pressure, but two other parameters are arterial resistance, and then a little bit more sophisticated aspect of looking at the dynamics of pressure and flow relations in the arterial system is the arterial impedance. So each of these different parameters has its place depending on what your application is and what your interests are, but also each of them has its own specific drawbacks. So it's important to understand the strengths and weaknesses and how it relates to your application. Again, for my own use, I tend to use the word afterload as an adjective, and I always qualify it with what exactly it is I'm talking about. The most common, I think most useful index of afterload is the total peripheral resistance, because conceptually, for the intact ventricle, we're looking for a measure of our afterload that provides a quantitative index that uniquely characterizes the arterial system independent of what the heart is doing and what the preload system is doing, so independent of preload and afterload. Such an index can be derived from the relationship between the mean pressure and the mean flow through the system. And that is really the definition of the TPR, is the difference, is the pressure gradient across the systemic vascular system divided by the cardiac output, and it has as its basis, in essence, Ohm's law, where you see here that the pressure gradient across the vascular system is dependent on the flow and the total peripheral resistance. So the TPR is basically independent of how much flow there is and how much preload is on the ventricle, and that really qualifies that as a viable index of afterload that satisfies the criteria of being independent of preload and afterload. I won't go into the other indices, but just suffice it to say that vascular impedance is a more generic form of TPR and allows one to not only interrelate mean pressure and mean flow, but also allows one, very importantly, to interrelate instantaneous pressure to instantaneous flow. So I won't go into any further detail about that. But this is what happens when you change the afterload on the ventricle. So here's the baseline loop. And now if you increase the TPR, you'll have an increase in pressure generation, and in this case, a reduction in the width, meaning a reduction in the stroke volume. If you decrease the TPR, the loop gets shorter, meaning less pressure generation, but is able to eject more, so the stroke volume increases. Again, as I emphasized before, the loops change their shape and their position, but they exist within the boundaries that are established by the end systolic and the end diastolic pressure volume relationships. So that is preload and afterload. Now a quick view about contractility. And again, going back to the sarcomere, here we have, again, the muscle length and the isometric force development. And in the red, we have the baseline condition. And what happens in the sarcomere if we change if we impose an intervention that modifies the intrinsic strength of the muscle? What we observe is that at any sarcomere length or at any muscle length, we can see that there's either an increase or a decrease in the force at that length depending on the intervention. Most commonly, things that change the contractility in this manner or change the intrinsic force generating capacity of the muscle relate to interventions that modify the amount of calcium that's released to the myofilaments or to the sensitivity of the myofilaments for calcium. So for example, beta blockers have an effect to limit the amount of calcium that goes through the calcium channels, and those act as a negative inotropic agent in the short term. Same thing for a calcium channel blocker, directly reduces the amount of calcium entering the cell, and therefore at any given length we've got a reduction in the force generating capacity. On the other hand, if you give a beta agonist, for example epinephrine or dobutamine or isoproterenol, those drugs act to increase the flux of calcium through the calcium channel, and they increase the amount of force that can be generated at any given length. Another example is if there's a change in the pH, intracellular pH modifies the myofilament sensitivity. So even if you have the same amount of calcium, if you have a drop in your pH, you'll have less force production at any given length than if you have the normal a normal pH. So this is again the basis for this what we see at the ventricular level, and it turns out that if we compare from a baseline state, things that increase muscle strength, muscle contractility, are called positive inotropic agents. These increase they shift the end systolic pressure volume relationship upward and leftward, and things that have a negative inotropic effect shift the relationship downward and rightward. In the ideal world, these shifts are really manifest as changes in the slope of the line with relatively little change in the volume axis intercept. So because of that, what we, and I mentioned before that these relationships are defined by the V0, which is the volume axis intercept, and the slope, the EES. These lines a change in contractility is mainly manifest and characterized by a change in the end systolic elastance EES. So increases in EES signify an increase in contractility, and decreases in EES signify a reduction in contractility. These loops show then what happens if you change contractility and you keep preload constant and you keep afterload resistance constant. What you see as the contractility is increased, you have both an increase in pressure generation and also an increase in flow performance. So the stroke volume is increasing, and the pressure, peak pressure, is also increasing. So this is how contractility, changes in contractility are manifest when there's no change in preload pressure and no change in afterload resistance. What about diastole? Again, in terms of the passive properties of the ventricle, they are described by the end diastolic pressure-volume relationship, and I've already shown an example of one of the equations that's used to define that relationship. Now, in terms of how people think about diastole, I think, and quantify diastolic properties, I think this is where there's the most confusion and most difficulty in how to analyze these things and how to present them. And that's mainly because the relationship is nonlinear, and therefore you can't define it by a simple parameter like the end systolic elastance, which describes the performance of end systole no matter what the loading condition is. The problem with diastole is that the mechanical properties of the heart depend on the loading conditions. So if you think of just the heart as a elastic chamber in diastole, and you want to understand its stiffness, you would be looking at the slope of the line that describes the pressure-volume, its pressure-volume relationship. So the stiffness is actually the slope, and the compliance is the reciprocal of the slope. So when you're at a low filling pressure, the slope is shallow, so you have a low stiffness and a high compliance. But as you fill the ventricle, you have a higher slope. That means a higher stiffness and a lower compliance. So therefore, if you're comparing compliance of one heart to another, you have to recognize that you can't, first of all, you can't just take the ratio between pressure and volume and call that compliance, because that will not be the local slope of the line. And also, if you're talking about compliance and you measure it properly by looking at the slope at the local area, you can't just pool data from different conditions where the preload is different, where the filling pressure is different, because you're going to be artificially making a incorrect conclusion about compliance simply because you're making measurements at different pressure settings. Now, in addition to that, the end diastolic pressure-volume relationship is not a fixed parameter, is not a fixed characteristic, but it can change. Unlike the end systolic pressure-volume relationship, which really can change on a beat-by-beat basis, either due to arrhythmias or to administration of drugs, the end diastolic pressure-volume relationship more reflects fundamental aspects of the structure of the myocytes and the geometry of the ventricle and the properties of the extracellular matrix. So while this can change, it's not a thing that really changes on a beat-by-beat basis, but it's something that takes time to occur. So for example, you can have shifts of the end diastolic pressure-volume relationship, as shown here, and this occurs very commonly in the setting of heart failure. And what happens in heart failure is that when the contractility of the heart is reduced and the body's autonomic nervous system imposes neurohormonal and chronic elevations of end diastolic pressure, that imposes over time structural changes to the myocytes and to the extracellular matrix and to the geometry of the ventricle. All those three things and other factors cause progressive shifting of the end diastolic pressure out towards larger volumes. That process is referred to as remodeling and is a fundamental and very important thing to study and to understand. So if your research involves heart failure, looking at the end diastolic pressure-volume relationship and looking at changes in the end diastolic pressure-volume relationship in response to interventions is an extremely important part of evaluating and characterizing the disease state and also the impact of a therapy. In addition, not only can that curve shift to the right towards larger volumes, but it also can shift towards the left in response to certain diseases. and in particular diseases such as hypertrophic cardiomyopathies, infiltrative diseases, and restrictive cardiomyopathies cause leftward shifts compared to normal of this curve. So again, if you're interested in, for example, a very important area of research now in cardiology is heart failure preserved ejection fraction, previously called diastolic heart failure. There's a lot of focus on how this relationship shifts and what's the impact of those shifts on the cardiovascular performance. Now, relaxation has two components. One is the end diastolic pressure volume relationship, which describes the extent to which the heart can relax and is characterized by the end diastolic pressure volume relationship. But there's another important aspect of diastole, which is the rate at which the heart relaxes. And that is really characterized by the rate of reduction, by the rate at which the pressure falls during the diastolic phase of the cardiac cycle. And it turns out that this fall is roughly exponential and can be therefore characterized by a time constant. So this, as you probably know, relaxation is very sensitive to the energy supply to the myofilaments. And in ischemia and in hypertrophy and disease states where energetics are altered, the time constant of relaxation is one of the first things that is affected. And it's very sensitive to the energy supply demand on the heart. So if we look at the rate of relaxation, this is influenced by changes in contractile element isoforms. It's impacted by the heart rate, which is really related to the change in the kinetics of calcium uptake, related to the energy supply, and also is related, impacted by the state of beta activation, beta adrenergic activation, because that impacts on the rate at which calcium is sequestered back to the myofilament, and that, after all, is what underlies this the rate of relaxation. So when thinking about diastole or lusitropy, it's very important to think about both the passive properties and the active aspects of diastole. So that is a very quick run-through of the basic aspects that one needs to know to become familiar with, to launch into the next level of understanding, which is to really understand what are the actual quantitative determinants of cardiac output and blood pressure. We need to know how to think about and quantify preload. We need to know how to think about and quantify afterload. We need to think about and know how to quantify contractility. And we also then need to know about the same thing for active and passive aspects of relaxation and diastole. So I am not going to go into any further details about this next step because it's in and of itself is a series of lectures. It's very interesting, but I wanted to really just review these basic aspects to whet your appetite to go further, to really understand really how these four basic fundamental principles are defined and can be used. And now, just to switch back to this Harvey, this application, what I want to do, for those of you who might have further interest in going deeper, there are, of course, many different resources that one can go to. But we've been working on developing this one for the last years or so, and as I mentioned, this app is currently available. Part 1 is currently available for the iPad, and it's called Harvey, spelled H-A-R-V-I, and it works on the iPad but not on the iPhone. So if you're looking on an iPhone for this app, you won't find it. You have to look on the iPad. And Part 1 is out. We're hoping to release Part 2 in the next month or two. Part 1 deals with the basic concepts. Part 2 deals with advanced physiological concepts. Part 3 gets into pathophysiology, disease states, and therapeutics. And Part 4 deals with mechanical circulatory support. So these really build one on top of the other. The concepts that I've discussed today really are the essence of book one, but with further detail. When you go into the books, you see the chapters that are here, and then if you go into any one of these chapters, let's, for example, go into the chapter on contractility, you'll see, first of all, at the top, you'll see a key points. So this is basically the cliff notes if you don't want to read the whole chapter and you just want to get, the essence of what contractility is and how it's quantified and what happens when you change it. You could read that. Otherwise, you can read, the text. These texts are intended to be readable within about 15 minutes each chapter. And then a unique feature is that each chapter has what's called a Try It Now button. And when you press this button, a pop-up window occurs, and it brings you to an interactive simulation where you can vary that one parameter and see the impact on the loops and on several different of the parameters. So, for example, this is the pop-up window on contractility. And what you're seeing here is I can change that one parameter by moving the slider, and then I can see how the loops change, only that one parameter, and see its impact on pressure generation, cardiac output, and filling pressures and filling volumes. And at the end of each chapter, there is, you can go into some self-assessment questions, and they start out with very simple, multiple choice questions, but then it goes into more complex questions that really poses a problem and requires further thought and evaluation to answer these questions. And to answer these questions, they're designed so that you need to go into a more thorough cardiovascular simulation and, in essence, perform a small experiment and collect data and understand what happens. So what you see here is how the simulation looks. On the left side, over here, are input parameters, and on the right side are output parameters. There's a lot of ability to customize the screen, and what you can see here is, unfortunately, that it's off screen. But what I'm going to do here is, for example, just show you to change a parameter, you hit the number, and then you've got a slider. And so here I'm reducing the preload, and you can see what happens on a beat-by-beat basis to the pressure volume loop, and you see what's happening in the time domain. On the right side are the outputs, and you can see that you've got pressures, you've got volumes in the right and left ventricles, you've got cardiac output, you've got ejection fraction. There are other aspects that are shown here, other features like the energetics, like what's the oxygen consumption of the system. At the bottom, you can customize this to look at both at pressures, volumes, and flows in the time domain. So you can customize how this looks. And there are a lot of features that are for saving parameters, loading parameters, etc. So that's a very quick overview of the app. Again, as I mentioned, the advanced concepts book is going to be out. These are the essence of the chapters that are going to be coming up about valve functioning, energetics, coronary perfusion, pharmacology, force interval relationships, which are necessary for understanding the hemodynamics of arrhythmias, Bauer reflexes, the pericardial constraints, interventricular interactions, and also there's going to be a chapter on the autonomic nervous system. So that's a very quick run-through of the basic concepts I wanted to introduce, and also then the Harvey app. So I think at this point, Andy, I'll turn it back to you to see if there's any questions.
That's perfect. Thank you very much, Dan. That was excellent. A lot of information shared, and again, for everybody, this whole session, recording, slides, and what we collect in this Q&A session will be available to all registrants and attendees. So yes, we've had lots of activity on the questions board. I've selected a few that I think we should open for discussion now, and then obviously we can't get to all questions, so this will be again followed up with a report after. So for those conducting research, this is a question that came up quite often in my past life, and someone has asked, what is the best way to choose loops to analyze occlusion data? So, maybe at the highest level, what are some ways in which some people can follow some rules as far as selecting families of loops, generating load-independent measures?
That's a great question, and it's obviously not a simple, straightforward answer, and there's a bit of subjectivity to it. First of all, it's important to start, the first consideration is what method are you using to measure the loops. And the two main, if you're measuring online things, the two main ways are with a conductance catheter or an impedance catheter, and with sonomicrometry, where you're assessing volume by sonomicrometry. If you're using a conductance catheter, you have to be careful when you do an IVC occlusion, because things change on the right ventricle first, in the right atrium, before they change on the left ventricle, and that can change the parallel conductance. So there's a period of time where you might see a slight leftward shift of the loops, where it's really a reflection of a change in the parallel conductance as opposed to a change in the actual volumes of the ventricle. So you've got to be careful at the very onset of an IVC occlusion with that technique. With the sonomicrometers, you don't have that problem.
Okay.
That's point number one. Point number two is you've got to be careful that you are not including beats that are arrhythmias. So again, when you change the load, sometimes you can induce arrhythmias. And you've got to exclude not only the beat that's arrhythmogenic, but a beat or two after that, because the contractility is interval dependent, and that interval dependence has a history. So if you have a single PVC, and then the influence of that could be felt 2 or 3 or 4 beats afterwards, depending on how premature it is. So that's where there's a little bit of subjectivity. So what you're looking for are loops whose points, end-systolic points, fall along a reasonably linear line. And it's usually easy to identify loops whose end-systolic pressure volume points either fall below or above the prevailing family of loops. And that's where a little bit of the subjectivity comes in.
Mm-hmm.
The final thing is that if you hold your IVC occlusion too long, and you have a prolonged period of hypotension, you activate the sympathetic nervous system, and then you start changing contractility and heart rate and whatnot. So the way to look at that really is to make sure that the heart rate is reasonably constant during the period of time that you're going to include the beats. If the heart rate starts increasing towards the end of the occlusion, you really don't want to include those beats.
Mm-hmm. And I mean, I agree completely, and your point about it being somewhat subjective and unique in case is that the experimental conditions play into this as well. I mean, controlling heart rate, moving through the IVC occlusions as a technique has the same way from experiment to experiment really all kind of accumulate as a process where it is subjective, but having these guidelines is definitely a help. On the same accord, we've had someone just post a quick question about fitting the ESPVR curve, either linear or exponential fit. Do you have any comments for that?
Sure. This is dealt with extensively in the review paper that I mentioned, and I think it depends on what your purpose is. But I've described the ESPVR in its ideal state as being linear with a intercept that doesn't change when you change contractility. But depending on what range of pressure and volume points you're able to achieve, the line may or may not be exactly linear. What's important in the research area, as opposed to, say, this educational aspects where we're looking at ideal conditions, it's always important to, no matter what equation you wind up using to fit, you should report both the V0 and the EES, because if the line is nonlinear and you just report the slope, you will be misled as to where what the impact of an intervention is. So you need to not only report both, but in a statistical analysis, you need to account for shifts of both, meaning not just doing independent, 2 separate pair t-tests on V0 and EES, but using a more sophisticated statistical analysis like multilinear regression analysis. And this is all detailed in the review article that I mentioned. I think what's important in the end is the position of the end-systolic pressure-volume relationship relative to each other when you're looking at an intervention. Not necessarily in pure terms the slope or the V0. It's really the relative position of these to each other in a comparison. We actually have also advocated, and this is in the review article also, is just using what we call an index. For example, we call it V120, which is what is the value of the volume where the end-systolic pressure-volume relationship crosses 120 millimeters of mercury. Therefore, in that way, you would be able to look at you're just saying, okay, I'm looking at it, this is a pressure value that I'm interested in the range that I'm working in for, this as an example, 120 millimeters mercury, and where does the pressure volume loop fall in, where does it intersect, what volume does it intersect that pressure? So leftward shifts would indicate, smaller V120 would indicate increases in contractility, and rightward shifts would be a higher V120 would be a lower index of contractility. So here's where it's important to understand the subtleties of what goes into defining the ESPVR, how to quantify it, how to statistically analyze it, and how to properly present it in a manuscript.
Yeah, that's listening to this answer, it highlights the the complexity of PV loop science in the research area. It's a visual science. There's no hard and fast rules and regulations really to analyzing and presenting data, but it's being aware of all these caveats, right?
Yeah. By the way, I think this is the biggest error that I see in papers is when investigators only report EES and fail to report both and do an improper statistical analysis. I've been invited to write a few editorials on such papers, and it makes a big difference. It makes a big difference in the conclusions that you might arrive at.
Yeah, and actually, I'm glad you brought that up because that will be something we're going to be trying to touch on throughout this web series is the statistical component, right? Data management and interpretation, and then what best practices really need to apply. So yeah, it's very good that you mentioned that, Dan. And actually, just on this note, someone has provided just a nice question. What is the difference between Emax, EES, and then elastance? It just reminds me that these terms are often kind of used interchangeably through papers and maybe incorrectly, as you were saying before. So maybe provide a quick clarification for the group.
This is a very subtle point, and it's really of historical importance because I happen to know the answer because I did my thesis work in the lab where these terms were developed and researched. So Emax was derived by looking at the time-varying elastance. So to define the time-varying elastance, what you do is, for example, you take 2 or 3 or 4 loops and you line them up in time, 2 or 3, 4, whatever loops under different loading conditions. You line them up in time, and you've got their pressure volume points at each instant in the cardiac cycle. And at each instance, you perform a regression analysis at that instant in time, and that will give you, if you just use a linear line, that will give you a slope as a function of time, and that's the time-varying elastance. The peak of that curve, which is the peak slope of the isochronal pressure-volume relationship, is called Emax. So that is what Emax is. EES is the end-systolic elastance and does not take into account time. So in pressure-volume loops, there may be subtle changes in the time to end systole that are a function of the loading conditions. This is a well-known phenomenon in muscle. So in muscle, if you increase the sarcomere length, the time to peak pressure, the time to peak force increases. So if you look at loops that are obtained over different loading conditions, they don't reach the end-systolic pressure-volume relationship at the same instant in time. So we changed the name from Emax to EES just to say it's the end systolic elastance. It's a very subtle point.
Yes,
and highly
but important.
Technical.
Yeah, highly technical and very important, I presume.
Yeah.
That's excellent. Thank you for that that answer, Dan. We've got way too many questions that we couldn't possibly answer live, and we've come to that moment where it's probably about time for us to wrap up. But as for all of those online with us now, again, our process is that we will take everyone's questions and include that as part of our Q&A report, and all of these informations are then forwarded on to registrants and attendees following our live events, and then always available online at Inside Scientific. So yeah, I'd like to kind of close our Q&A session now. If people have additional questions related to PV loops and part of the web series, also feel free to use our events at insidescientific.com email address as an area where you can send in general questions. Maybe just indicate that it's relating to Dan's talk today, and that will, again, just allow us to bring all this feedback and information together and share it with the community. So, officially thank you everyone for registering for the full web series and for taking part in the first session today. For those that do not have an account at Inside Scientific, we encourage you to log in. You have the opportunity to provide us some additional details about yourself, the research and focuses and interests you have, and that allows us to keep you informed of events that match your interests. And then finally, our coming sessions will be hemodynamic assessment series. This will be part 1, a PV loop case study, and this will be sponsored by Transonic. And then in addition, we have Indus Instruments joining us again to provide a dedicated example or coverage of improving PV loop results through proper heating and monitoring during surgery. And we hope to have this more of a video format so that it's a resource that will show you live with pictures and video on how to best optimize your surgeries and then drive better results in the PV loop research application. So finally, Dan, I just want to thank you again. It's always a great pleasure working with you, and I hope we have a chance to work together again moving forward. So again, thanks, and everybody have a wonderful day.
Thanks very much.